So, kidneys are the respiratory organs, is it not? So, kidneys are the excretory organs which excrete urea. Okay, nitrogenous base. Is it urea? Is it not? Nitrogenous base. Okay, all the way from protein metabolism. Protein metabolism will be giving rise to nitrogenous based materials like urea and everything. That will be excreted outside through the kidneys. Is it not? So, what are the hormones which are secreted by the kidney? Renin, which balances the blood pressure, and then erythropoietin. So 125 dihydroxy cholecalciferol for the calcium metabolism, right? So these are the endocrine functions of the kidney, right? So where does the kidneys are situated? What are the kidneys actually? Kidneys are retroperitoneal structures, so they lie behind the peritoneum, obviously. Okay? So exactly behind the stomach, almost behind the stomach and the liver are both the kidneys. Is it or not? Topographically, okay. So kidneys extend between T12 to L3 vertebral levels. Okay, T12 to L3 vertebral levels. This is for the right kidney, because there is a liver which pushes the kidney downwards over here. But towards the left side, we may extend up to T11. Okay, T11 to L3. Why? Because the left kidney is a bit longer compared to the right kidney. Getting it out? Narrower and longer than the right kidney is the left kidney. And one more thing, there is no liver on the left side, so it will be extending till the T11 vertebral level over here. So which pleura will be coming in contact, not in contact, in relation to the kidney over here? Which kidney? Obviously the left kidney. Okay. So the right kidney will be below the 11th intercostal space, so pleura will not come in contact or in relation with the right kidney, but pleura will be coming in relation with the left kidney over here. Nothing but costo-diaphragmatic recess over here. Got it? Costo-diaphragmatic recess. So how the kidneys are kept in position, just like the liver, within the posterior abdominal, towards the posterior abdominal. What are the structures? These things are important. What are those? First of all, the surrounding viscera. What might be the surrounding viscera over here with respect to the kidneys? In front of the kidneys, spleen exactly, and any other? Any other? Towards the right side, which structures are in front of the kidney? Duodenum, liver, and spleen, and stomach. All these viscera will be lying in front of the kidneys, so they will keep the kidneys in position, just like the liver. Okay, and the hilar structures, hilum of the kidney structures. What are those? The things which are entering and leaving the kidneys. Nothing but the renal vessels, and then pelvis of the ureter. Okay, pelvis of the ureter, and renal vein and renal artery will be keeping the kidneys in position, just like the liver by means of hepatic veins over here. Got it? Right. And one more thing, kidneys are surrounded by the capsules, different capsules that will be hanging towards the diaphragm. So that in that manner also kidneys will be kept in position. So the viscera which are lying anterior to the kidneys, along with the intra-abdominal pressure and the capsules surrounding the kidneys and the hilum structures, everything will keep the kidneys in position towards the posterior abdominal wall. So if the kidneys are not kept in position, if they are hanging, what will happen? What will happen if the kidneys are hanging within the abdominal cavity? Okay, let it move. What will happen? The lungs are also moving, spleen is also moving. What will happen? Kinking of the ureter and constriction of the vessels also will occur. Is it not right? So whenever the kidney is in normal position, whenever it is dislodged from this normal position, the ureter will be kinked. That means there will be a narrowing of the ureter over here, and also the blood vessels will be crushed or constricted over here, leading to the ischemia to the kidneys, and of course there is a term called hydronephrosis. We'll discuss that later. Okay. So these are the problems if the kidneys are not kept in position. Getting it down it? Right. So what is the long axis of the kidney? What is the long axis? These axes will be asked in the examination, the white one. Okay. See here the right kidney over here, all the way from T12 to L3 vertebra over here, and the left kidney will be extending all the way from T11 till the L3 vertebra, because it is narrower and longer than the right kidney over here. Okay, this you are supposed to know. Okay, what's the long axis? See properly over here. The distance between the vertebra or from the midline till the upper end of the kidney over here is about 2.5 centimeters. This theoretically you are supposed to know. 2.5 centimeters. And the hilum will be from the L1 or from the midline at the level of the L1 will be about 5 centimeters, and from the L3 towards the midline it will be about some 7.5 centimeters. See properly over here. This is the upper pole of the kidney and this is the lower pole of the kidney. This upper pole is very much close to the midline or very much close to the vertebrae over here, but the lower pole is far away from the vertebrae over here. Okay, so this upper pole will be about 2.5 centimeters from the midline at the level of T12, and the hilum at the level of lower border of L1 about 5 centimeters from the midline over here. So if you see properly, 2.5 centimeters, 5 centimeters and 7.5 centimeters. So the axis, long axis of the kidney is obliquely downwards and laterally situated. Getting it out? The long axis of the kidney is obliquely downwards and laterally situated over here. Okay. Then coming to the transverse axis. Transverse axis, the kidneys, for example, if this is towards the hilum of the kidney over here, the kidneys are situated not in this manner. For example, this is the hilum, okay, towards the ductus side, this is the hilum over here. So the kidneys will be situated in this manner. Will you understand? So this is here where the renal vessels will enter and exit out. Why it is situated in this manner, not horizontally? Logical question. No. Uterus all the way from around the vertebrae. What might be the reason of it? We have seen duodenum, it is facing backwards. Is it not? Liver, it is situated obliquely backwards. Why so? What is the reason?
Because it is based on the
Paravertebral, that is the answer. Okay, kidneys are situated on either sides of the vertebra within the paravertebral gutter. So the gutter will be taking the kidneys towards in this manner. Getting it over? So the hilum will be facing a bit forward over here, forward and medially over here. So the transverse axis is directed laterally and outward. Okay, outward and laterally over here, not inward and medially over here. Outward and laterally in this manner. Getting it over? So this is the transverse axis of the kidney and this is the long axis of the kidney over here. Got it out, everybody? Right? Now coming to the coverings of the kidney, what are the things which are covering the kidney over here? This is very much important, it will be a short notes. So the kidney, anywhere in the body, any gland over here will be secreting fibrous stroma. If you take a thyroid gland or prostate gland or whatever it might be the gland, the substance of the gland will be releasing fibrous stroma. You know the fibrous stroma, isn't it? So that will be lining the entire gland very much adjacent. Immediately next to the substance of the gland will be the fibrous capsule, which is the true capsule of it. Anywhere in the body. Anywhere in the body, immediately next to the substance of the gland will be the true capsule. Outside of the true capsule will be the false capsule anywhere in the body. Okay. In the same manner, kidney is also surrounded by a true capsule over here. This true capsule will be going along with the arteries and veins also. This true capsule will be encroaching over the arteries and veins also. Getting it on? the true capsule will be encroaching a little bit towards the renal vessels over here till the hilum. Hilum of the kidney is not this part over here. Hilum of the kidney is this part. We'll be discussing that later. Okay. This is not the hilum, just like the lung or liver, whatever it might be. Okay. But hilum is a bit in front. This part of the kidney towards the hilum is termed as sinus of the kidney. We'll discuss that later. Okay. But for now, remember, this is not the hilum of the kidney. It is a bit in front over here. Okay. So whenever the vessels are entering into the sinus of the kidney, it will be occupied by this capsule, which is called true capsule. Okay, true capsule. Okay. And then true capsule is surrounded by perinephric fat over here. Around the kidney is the perinephric fat. This layer is called adipose capsule, because it is made up of adipose tissue and it is in the form of a capsule over here. This capsule is called adipose capsule, and the space over here, okay, we'll discuss the space later. Okay, first of all, the true capsule, immediately next to that will be the fat, which is called the perinephric fat. Around the kidney is the fat, throughout, front and back and above and below, will be occupied by the perinephric fat, and this fat is forming a capsule sort of structure, that is nothing but the adipose capsule over here. Okay, adipose capsule. Above the adipose capsule, there will be one more capsule, that is called the false capsule over here. Fascia of Zeruta, exactly. So outside the adipose capsule, there is one more fascia called false capsule or fascia of Zeruta over here. Okay. So standard book says that the anterior layer of this false capsule is termed as fascia of Zeruta, and posterior layer is termed as Zucker cantle. But what you are supposed to follow is the entire fascia over here, which will be accepted by the examiners and everyone. So this entire false capsule outside the adipose capsule is termed as fascia of Zeruta over here. Okay, not the anterior layer and posterior, don't differentiate that. Fascia of Zeruta, which is nothing but the false capsule over here. So in between the true capsule and false capsule, this space is termed as space of Zeruta. In between the true capsule and false capsule, the space. This space is termed as the space of Zeruta, which will be occupied by the adipose capsule. So fascia of Zeruta and space of Zeruta, both are different, absolutely different. Okay, right. So this is the, what is capsule? False capsule over here. So this false capsule, there are few extensions of the false capsule over here. Laterally, so this false capsule contains two layers. One is anterior layer and one is posterior layer. The anterior layer is termed as fascia of Tolt. One more fascia of Tolt over here. One behind pancreas, body of the pancreas. And one is fascia of Zucker. Zucker candle. Okay. Zucker candle. Fascia of Tolt on the anterior layer. Nothing but the anterior layer is fascia of Tolt, and posterior layer is fascia of Zucker candle. Okay. Remember these terminologies. These are short notes and of course the viva, especially viva questions over here. Okay. So the true capsule only one layer and will be encroaching over the renal vessels over here, and then followed by the adipose capsule, which is made up of adipose tissue over here, and that is also single layer over here, which will be occupying around the area around the kidney over here, and then followed by the false capsule, which consists of two layers. One is on the anterior layer and one is posterior layer. Anterior layer is called as fascia of Tolt, posterior layer is termed as fascia of Zucker-Candle over here. Okay. So these two layers, whenever they are joining at the lateral border, this lateral border will be continuous with fascia transversalis. Fascia transversalis. The lateral border of this fascia will be continuous with the fascia transversalis. Could you able to imagine? For example, kidneys are situated in front of the posterior abdominal wall muscles. Is it not? Right? Because there will be from T12 to L3 on either sides of the vertebra, there will be psoas major. First of all, there will be psoas major in this manner. Beside that will be quadratus lumborum. Even further will be transversus. The transversus abdominis over here. In front of all these will be fascia transversalis. Could you imagine? So behind the kidneys and in front of these muscles is the fascia transversalis. So behind the kidneys is the fascia of Zucker-Candle. In front of that is the fascia of Tolt. Both will join together by the lateral aspect, and that will be continuing with the fascia transversalis. Could you understand? Right. So laterally it is the extension over here, and medially it will be extending over the vessels. What are those vessels which are present over here? Towards the vertebra, in the center of the vertebra will be aorta and inferior vena cava. So for example, if there is aorta over here and inferior vena cava over here. Okay. So this fascia will be going in front of the vena cava, inferior vena cava, and in front of the aorta, and joins with the opposite false capsule over here. Getting it? Again, it will be continuous over here and over here in this manner. Getting it? So this is the left kidney's false capsule. So it will be the communication in this manner. Getting it? And one more thing. So this part is the sinus of the kidney. We will discuss that later. Sinus means a cavity sort of in the middle of the medial border of the kidney. This is the entire medial border over here. In the middle there is a concavity apart from convexity. So this will be forming a cavity over here in this manner. That is called the renal sinus, into which the hilum will be situated over here. Getting it over? So at this point, this will be giving rise to, the false capsule will be giving rise to a deeper lamina over here. Here this part is a superficial lamina over here, but into which anterior-posteriorly connecting the anterior layer and posterior layer. Here the two anterior and posterior layers are joined with each other and continues with the fascia transversalis as a single layer. Here also anterior layer will be present, and behind also posterior layer will be present over here. So both layers over this part are connected by means of a deeper stratum. This is a deeper stratum. This is a superficial stratum. Deeper stratum will be going horizontally in this manner. Getting it out? So for example, if this is the two layers, anterior layer and posterior layer, and in front of the sinus will be, this is the deeper stratum. This part is the superficial stratum, and this duster is the deeper stratum over here. Going absolutely in front of the hilum and the sinus over here, and joining the anterior and posterior layers, and it closes this sinus of the kidney over here. Now sinus will be in this manner. Here will be the kidney, and here will be the deeper stratum of the anterior and posterior layers over here. On either sides will be anterior layer and posterior layer. Now the sinus will be in the form of a closed cavity over here. Got it or not? Right? So this sinus in front will be the deeper stratum of the false capsule. Behind will be the kidney over here. In front will be anterior layer of this false capsule. Behind will be the posterior layer of the false capsule. Now everything is a nutshell sort of. Got it or not? And this forms the sinus, which contains various structures like pelvis of the ureter, renal artery, renal vein, lymphatics, and the nerves over here. Got it or not? Just like a nutshell, all the structures which are entering into the hilum of the kidney will be present in the renal sinus over here. Understood or not, everybody? Right? So that's why if it is getting dislodged because of this lack of capsules or whatever it might be, there will be kinking of the ureter, and there will be shrink or constriction of the blood vessels over here. Getting it or not? Right? So this is the false capsule towards the lateral aspect and towards the medial aspect over here. And further it will be these two layers after giving a deeper stratum over here. Further goes forward in front of the vena cava and the aorta and joins with the medial aspect of the left-sided kidney's false capsule over here. Understood or not? And this is the communication between the two false capsules on either sides. Right or not? Understood or not? Right? Now, so we have seen laterally and medially, above and below. Above, it will be enclosing a space over here for the suprarenal gland over here. Suprarenal gland over here. For example, the right suprarenal gland over here, left suprarenal gland will be in this one. Okay. Right suprarenal gland, if you take, see here, just below the suprarenal gland, this false capsule is continuous with the kidney over here. Okay. But above, again it will be divided into two layers over here, and that will be enclosing the suprarenal gland. Getting it out? First of all, the two layers, anterior and posterior layers, enclose the kidney and join with each other over here. Anterior layer and posterior layer join with each other over here. But again they will divide and again forms the anterior and posterior layers and joins above the suprarenal gland. Understood or not? Right? Initially the two layers, if you take in sagittal section, anterior layer and posterior layer over here. Anterior layer and posterior layer both have joined above over here, above the kidney. And again they will divide and enclose the suprarenal gland over here. Understood or not? Right? And this will be joined with the diaphragm over here. Above will be the diaphragm, subdiaphragmatic fascia will be present over it. There is a diaphragm, below the diaphragm will be, obviously there will be peritoneum, parietal peritoneum. Parietal peritoneum, the connective tissue part will be towards the diaphragm and the epithelial part will be towards the peritoneal cavity, isn't it? So in between the diaphragm and the epithelial part there is a connective tissue, isn't it? That is called the subdiaphragmatic connective tissue. Below the diaphragm is the connective tissue. Okay. So this fascia and that connective tissue is made up of same material, same collagen fibers, blood vessels, stem cell lymphatics and everything. Okay. So this joining part of anterior and posterior layers over here will be straight away communicating with the subdiaphragmatic fascia, forming suspensory ligament of suprarenal gland. So this is the upward extension of the fascia of Geronta over here. Could you understand? Laterally for the fascia transversalis, medially both sides will be communicated. Above, it will again divide and enclose the suprarenal gland and again joins above and forms a single layer over here. That will be continuous with the subdiaphragmatic fascia over here, forming suspensory. This part is whatever it is joining above the suprarenal gland with the diaphragm is nothing but the suspensory ligament of suprarenal gland, because it is suspending the suprarenal gland. For example, if you separate this part of fascia and kidney, this will be still hanging to the diaphragm above. Getting it out? For example, if you are removing the kidney because it has damage or malignancy, whatever it might be, you are doing removal of the kidney over here, but suprarenal gland will be still hanging to the diaphragm because of the presence of this fascia around it. Got it or not? So that's why it is termed as suspensory ligament of suprarenal gland. Okay. So the kidney can be separated from this part of suprarenal gland whenever you divide the kidney from this fascia over here. Got it or not, everybody? Right? So below it will be continuous with, below this part of fascia will be, because ureter will be, pelvis of the ureter will be going in this manner, the lower part of the fascia will be continuous with the ureter and joins with the connective tissue of the pelvic cavity or towards the iliac fossa. Getting it out? Above, this fascia is continuous with the subdiaphragmatic fascia, and below the same fascia will be going along with the ureter and joins with the connective tissue deep to the parietal peritoneum in the pelvic cavity. Could you understand? Above, the upper limit will be the diaphragm, below the lower limit will be the pelvic cavity. Isn't it right? So above, this is connected with the subdiaphragmatic fascia, Below it is continuous with the fascia which is lying deep to the peritoneum of the pelvic cavity. Understood or not, everybody? Right? So these are the extensions of the what is false capsule over here. Outside the false capsule, there is one more fatty layer over here. Exactly. What is that? Paranephric fat. Paranephric fat is not completely around the kidney, but it will be in between the quadratus lumborum and the posterior surface of the kidney. Remember this properly. The paranephric fat, it is parallel to the kidney. Peri means around, peripheral, around. Okay. Peri means throughout the kidney, around the kidney over here. Para means only parallel to the kidney over here. Okay. Parasagittal plane, it's parallel to the sagittal plane. In the same manner, paranephric fat, it is parallel to the kidney, but it is situated in between quadratus lumborum behind and posterior surface of the kidney in front. You know, for example, quadratus lumborum is situated in this manner. For example, this is psoas major. Quadratus lumborum will be situated in this manner, and kidney will be situated in this manner. Could you understand? So this is the psoas major part, and this is the quadratus lumborum part, and the kidney will be in between these two muscles over here. So till this part is the psoas major, and this part belongs to quadratus lumborum on the posterior aspect. So this part is occupied by the paranephric fat. Only this part is occupied by the paranephric fat. On the posterior aspect, not on the anterior aspect. Getting it or not? Right?
So then how the vessels are entering and exiting there? I mean, the new stadium is there. So how are they passing there? Passing from there?
What's the word?
So the renal artery and
Renal artery vena there.
how are they passing?
That's what. For example, this is a kidney over here. Okay. So kidney is surrounded by below that. There is a true capsule. Okay. That will be extending till the ureteral blood vessels. We know that. So it is indirectly it is saying that it is pierced. This is pierced by the veins and arteries over here in this manner, right? Normally the connective tissue will be carrying the blood vessels and nerves. Okay. So this is a true capsule going along with the blood vessels over here in this manner, and there will be fat. Obviously fat can be easily pierced over here, and then followed by the false capsule in this manner. False capsule is also made up of connective tissue. So the connective tissue will be carrying the blood vessels inwards over here. There is no obstruction.
Okay. So these strata will be
No obstruction will be there. So normally any connective tissue, whether it's a dense or loose areolar connective tissue, the purpose of connective tissue is to connect the adjacent structures along with carrying the blood vessels, nerves and lymphatics. Is it or not? Is it or not? So do you think that what is that? For example, if you take the tendons, there will be connective tissue or not in between the fibers. Connective tissue is there. In the same manner, the connective tissue is present over here. Through the connective tissue, blood vessels, nerves and lymphatics will be carried. There is no obstruction. It is not a solid obstruction like a capsule. So it's like a loose areolar connective tissue over here. So through which the blood vessels can easily enter and go out over here. Okay. So everything is made up of a connective tissue, but it is not dense, regular connective tissue, just like in the ligaments or in the capsules. Okay. It is like a loose areolar connective tissue through which anything can pass, anything can go out easily. Okay. In that manner, blood vessels will pass. Okay. So let us see the borders and surfaces of the kidney. So let us see the borders and surfaces of the kidney. What might be the first of all, what might be the borders of the kidney over here? There will be a lateral border over here, and there will be a medial border over here. This is the lateral border which is convex, but there is a medial border. The upper 1/3 and lower 1/3 are convex towards the medial aspect, and in the middle part there will be concavity because of the presence of the renal sinus. Sinus means we have the sinuses, frontal sinus and everything. Those are the spaces. In the same manner, kidney also have a space in the middle part of the medial border over here. That is called the renal sinus, which contains pelvis of the ureter, renal vessels, nerves and lymphatics and the fat also. These are the contents of the renal sinus over here. Whatever are entering into the kidney, those are the contents of the renal sinus over here. Got it? Right. So medial border, which is convex, concave and convex again. Lateral border is convex as a whole. Okay. And this upper end and lower end are called poles, which are called the upper pole and lower pole of the kidney. Which pole is close to the vertebrae? Upper pole. Lower pole will be away from the vertebrae or middle. Okay, whatever. Some points. Okay. And then coming to the surfaces, there will be anterior surface which is convex in this manner. More convexity will be seen on the anterior surface, but the posterior surface will be flat. Getting it or not? Anterior surface will be convex in this manner, but the posterior surface will be flat. Okay, posterior surface will be flat. Okay. So these are the borders and surfaces and poles of the kidney over here. Understood or not, everybody? Right? So let us see the relations of over here. Relations of the kidney. You can easily say the posterior relations. What might be the posterior relations? Exactly. So on either sides of the vertebra there will be which muscle? Psoas major will be coming in this manner. Psoas major will be going in this manner. Okay. And just lateral to the psoas major will be quadratus lumborum, which will be going over here, deep to the psoas major. So at this point there will be a medial arcuate ligament and there will be lateral arcuate ligament also over here, right? So these arcuate ligaments are formed by medial arcuate ligament by means of psoas fascia, lateral arcuate ligament by means of thoracolumbar fascia. Which layer? Anterior layer of the thoracolumbar fascia. Okay. Here one thing you are supposed to understand. Whatever the fascia, renal fascia which is present in the posterior aspect, the posterior layer of the false capsule is termed as fascia of Zucker candle. Okay, Zucker candle. Okay, that fascia will be fused with the fascia, iliac fascia over here. Fascia iliaca over here. Okay, so sorry, psoas fascia. Okay, so to the psoas fascia, the posterior layer, nothing but the fascia of Zucker candle will be fused over here on the posterior aspect. Even this also keeps the kidney in position. Getting it out? So, if this is the quadratus lumborum, if this is the lateral arcuate ligament, few structures will be going deep to the lateral arcuate ligament. What are those? Subcostal nerve and vessels over here. And any other nerves? We have seen the lumbar plexus, iliohypogastric nerve above, and ilio-inguinal nerve below. Okay, this is an artery and this is a vein over here. On both the sides. Okay. So this is the lateral arcuate ligament. Now we are discussing on the posterior aspect. So beneath the lateral arcuate ligament, there emerges subcostal vessels nerve, which are the 12th nerve and 12th intercostal, not intercostal, vessels over there. And then followed by iliohypogastric nerve and ilio-inguinal nerve. So these are the relations of the posterior aspect of the kidney, or nothing but towards the posterior surface over here. Okay, so these things are common on either sides. Okay, and here will be running a larger trunk. What is the trunk? Sympathetic trunk, right? Sympathetic trunk and left sympathetic trunk will be going over here. Those will be the relations. Okay. So we have found out the posterior relations. Now let us see the anterior relations. That is very much important, which will be asked as short notes. So first of all, let us put the exactly. So we know that pancreas will be extending in between the two kidneys. Isn't it? Pancreas will be extending in between the two kidneys. So enclosing the pancreas, there will be duodenum. Is it not? Let us see the impressions over the right kidney and left kidney now. Okay. So what are the relations of different viscera which are keeping the kidneys in positions by giving the impressions of the kidney? These impressions are very much important, which should be definitely given in the essay question, you can say. Okay. So towards the hilum or towards the medial body, there will be impression for the duodenum over here. Which parts of the duodenum? Second part of the duodenum over here. Okay. Above the duodenum, what you might get? We have already seen that there is a presence of suprarenal gland over here. Suprarenal gland over here. So towards the upper pole of the kidney, there will be suprarenal impression over here. Suprarenal impression over here. Below that, towards the medial body, this is the duodenal impression over here. So, what might be this part will be occupied by? Exactly, liver. Right lobe of the liver will be giving the impression over here. Getting it over? Could you able to imagine the relations of the duodenum and everything with the right lobe of the liver? Right? So above the duodenum is the right lobe of the liver because this is the kidney over here. Okay. And then followed by further below will be colic flexure. Absolutely. Colic flexure will be going in this manner. Is it not? The colon will be going over here. We have seen the bare area of the liver over here. And what is this name? Hepatorenal pouch of Morrison. Absolutely. Hepatorenal pouch of Morrison. Somebody asked me hepatorenal pouch of Morrison. Let us see that once. Okay. Okay, let us see the trick. Let us focus this. For example, we are in the sagittal section. Okay, parasagittal section, we can see that. Okay, so this is the liver towards the right lobe of the liver, and this is the right kidney over here, and this is the right colic flexure, and this is the ascending colon over here. Okay, clear on it? So we are at this part, ascending colon, and the right kidney, and the liver in front. Okay. So the fascia which is covering the liver over here, fascia which is covering the liver, peritoneum which is covering the right lobe of the liver, and this part is the bare area of the liver. This part is the bare area of the liver towards the posterior surface. Okay. So this is the superior layer of the coronary ligament, and this is the inferior layer of the coronary ligament. On the opposite side, both will join and form a right triangular ligament that will be hanging the liver from right side. Okay. So this lower layer or inferior layer of the coronary ligament that will be extending over the kidney. This lower layer will be extending over the kidney and will be returns downwards and goes in front of the colon as the parietal peritoneum, making the kidney as a retroperitoneal structure and ascending colon also as a retroperitoneal structure. Understood or not? So if you join both of these layers over here, this is the inferior layer of the coronary ligament from the bare area of the liver. And here this layer is nothing but the parietal peritoneum covering the kidney and ascending colon and colic flexure as well with that of the parietal peritoneum. If you join this inferior layer with this parietal peritoneum, this is called the hepatorenal pouch of Morrison. It is not like pouch in this manner. It is pouch in this manner, upside down over here. Okay. This will become dependent area means, for example, if you are traveling in the bus, your foot and ankle will become swollen because of the edema. So towards the gravity, the edema is formed over here, not towards the head, right? So now the feet and the ankles are the dependent areas over here for the edema formation. And whenever the patient is lying supine in this manner, if there is any, for example, there is a urinary bladder injury over here in the pelvic cavity. So the urine will be leaked into the peritoneal cavity, and whenever the patient lies in a supine position, that can easily trickle towards this hepatorenal pouch of Morrison, infecting the liver and the kidney and the intestine as well. In this manner, this will become dependent in supine posture, but right iliac fossa will become dependent in erect posture. What do you want to do? So if there is any bile leak over here or any abscess leak over here, the pus leak over here. In erect posture, the pus or the bile or the secretions from the liver, whatever it might be, that will be trickling down into the right iliac fossa, making the right iliac fossa dependent over here. Understood or not? In supine posture and in erect posture. This is the difference. Understood or not? Right? Have to write about your Morrison. So by this you can understand, so this part is the duodenum which is overlapping over the right lobe of the liver over here. So towards the right side of the duodenum will be the liver over here. Is it or not? Right lobe of the liver will be giving rise to the impression over here. If you take the posterior aspect of the liver in this manner, posterior aspect of the liver. So for example, this is a quadrate lobe. This is the gallbladder over here. The duodenum will be going over here and will be taking a turn in this manner. Is it or not? Right? So here this part is the liver which is related over here. Get it or not? And colon will be giving rise to impression over here in this manner towards the liver, towards the posterior aspect, right lobe. So if you see that this is the second part of the duodenum, this is the colon flexure over here, and this part is free from all the impressions over here, apart from renal impression. Because kidney is getting the impression from the liver over here. So this part of the kidney is this part over here. So that's why this part is related to the liver. Which liver? Right lobe of the liver over here. And then further towards the left side will be the duodenum over here. Even below that will be the colic flexure, right colic flexure. So below the transverse colon and medial to the ascending colon there will be exactly the coils of jejunum will be present over here. Is it alright? Close to the transverse close to the transverse colon is the coils of the jejunum. Close to the sigmoid colon is the what is it? Ileum. Ileum. Okay. So just below the transverse colon, this lower pole is occupied by the coils of jejunum. So these are the impressions of the anterior surface or anterior aspect of the kidney. Getting it out? All the way from above downwards, this is the suprarenal, and then followed by duodenal, and then followed by the colic impression over here. And then towards the right half will be hepatic, and then right colic flexure and coils of the jejunum over here. So these are the impressions of the anterior surface of the kidney over here. Getting it out? Towards the left side, you can easily say what? Gastric. So towards the upper pole will be left suprarenal gland, towards the lower pole will be again this transverse colon will be going over here and will be turning back over here in this manner. So obviously left colic flexure above, and below to that will be coils of jejunum again, because the upper part and left part will be occupied by the jejunum over here. Above that will be what is gastric impression over here. Here will be, so far we have seen the spleen and stomach. If with respect to the stomach and the spleen is above and stomach is below, isn't it? So here this part will be occupied by the spleen and lower part will be occupied by the stomach obviously. So behind the stomach the pancreas is situated, isn't it? So that towards the upper pole you can see that. So towards the medial aspect will be the suprarenal impression, and towards the lateral aspect will be above splenic impression and below gastric impression in this arrangement over here. Okay. So this part will be occupied by the stomach. In between these two, there is a ligament called leno-renal ligament. Leno-renal ligament over here. Could you understand it? Because this is the hilum of the spleen over here, from which the leno-renal ligament will be going over here. Is it not? At the level of the hilum, the gastrosplenic ligament and leno-renal ligament will be going over here. Okay. So in between the spleen and the stomach, there is a leno-renal ligament. Could you able to imagine the relation over here? Could you able to imagine the relation or not?
Yes, sir.
Right. So if you put the spleen over here, for example, if you put the spleen over here in this manner, so this part is the hilum of the spleen over here. Splenic relation is over here. And from the hilum, the leno-renal ligament is going over here towards the kidney from the hilum of the spleen over here. But the stomach is situated over here. Could you understand? So stomach is related below, spleen is related above. In between the spleen and the stomach, all the way from the hilum is the lino-renal ligament over here. Got it out, everybody? Right? So these are the impressions over the anterior surface of the left kidney. So if you imagine the colon below and the stomach and spleen above, and in between all these things is the pancreas, you can make out the impressions over the right kidney and left kidney. Got it or not? Right? So this part is the colic part. Above is the gastric and splenic part. In between these two is the pancreas. Just put it in between the two kidneys over here. That's all. Got it or not, everybody? Right? So these impressions will be a short notes or essay question. Okay. So where is the hilum of the kidney? This part or this part? This part? No. This part is the hilum of the kidney, not this part. Remember properly. Okay. So this sinus is a part of the substance of the kidney. Okay, it's not a separate part. Okay. So if you are entering into the deeper structure of the kidney over here, it is divided into a cortex and the medulla over here. Okay, what are the two things? First of all, the kidney is covered by the capsules we have discussed so far. Deep to that will be the substance of the kidney towards the hilum. These are the structures. What are those? The outer part is called the cortex. What histology over or not, right? No? Over or not? Ready, Nigel? Right? Okay. Over. Very good. Then you must be telling me no? No? Okay. You can tell in the examinations, okay? Okay. So the kidney is divided into outer cortex and inner medulla. Medulla means nothing but it is the presence of renal pyramids. Okay. The renal pyramids, the apices are situated towards the sinus of the kidney or towards the hilum of the kidney over here. But the bases are facing towards the cortex of the kidney over here. This is very much important. In case of lungs also, how the segments are directed? The apices must be facing towards the hilum, but the bases must be facing towards the outer cortex or outer surface. Outer surface, no cortex, outer surface. Okay. So these things are basic. This you are supposed to know. Okay. So. So the area just above the base of the pyramid till the surface of the kidney, this area along with this medulla together is termed as lobe of the kidney. What is it? Lobe of the kidney. Lobe, could you able to understand? Wherever the pyramid is present, above the pyramid, whatever the part of the cortex is present over here, so both of these together is termed as the lobe of the kidney. Getting it over? So this is one lobe, this is another lobe over here, and this is another lobe. These differences you are supposed to understand. Okay. This is a question which will be asked in this 2 marks or something, whatever it might be. So lobes and lobules of the kidney. We'll discuss the lobules later. Okay. First of all, try to understand the lobes of the kidney. So this entire portion is termed as the lobe of the kidney over here. Pyramid along with the cortex which is just lying above the pyramid is nothing but the lobe of the kidney. Okay. And the area in between these two lobes is termed as renal columns. Absolutely. So this area in between the two lobes is termed as renal columns. What is it? Renal columns, which contains vessels over here. Both arteries and the veins will be present over here. Get it? So far we have found the cortex and the medulla and the renal lobes over here. Renal columns are also. Okay. So what is the content of the renal columns contains the vasculature over here, nothing but the renal vessels over here, nothing but the arteries and the veins over here. Then what is the content of the pyramids and this cortex, this part of the cortex over here? Basically the pyramids contain collecting tubules, okay, and one more loops of Henle and collecting tubules or collecting ductules over here, right? So if there are loops of Henle over here and collecting ductules over here, what structures will be present in this point? What? DCT, PCT, what are those? Convoluted tubules. This is not part of the nephron over here. So DCT, PCT, and one more. Bowman's capsule along with glomerulus, which is termed as renal corpuscle. Okay. So the renal corpuscle, nothing but the Bowman's capsule along with the glomerulus over here, and the distal convoluted tubule and proximal convoluted tubule, and few vessels and veins, nothing but the arterioles and veins will be the content of this part over here. Getting it over? Here only the tubules will be present over here. Do you think that the glomerulus will be present over here? No. Bowman's capsule also will not be present over here. Okay. Within this pyramid, if you take a pyramid as a whole in this manner, so there are loops of Henle which are which are reaching the. So this is a pyramid. This area where the multiple tubules will be opened is termed as papilla. Renal papilla. What is papilla? The apex of the renal pyramid with multiple tubules opening into it is termed as the renal papilla over here. Get it? Renal papilla over here. So wherever the tubules are going over here, there will be the loops of Henle in this manner and loops of Henle in this manner also. Few loops of Henle will be reaching the bottom over here, and few loops of Henle will be a bit away from the bottom over here. So which loops of Henle belongs to which nephrons over here? There are two sorts of nephrons. One is cortical and one is juxtamedullary. What is juxtamedullary means? Cortical means absolutely within the cortex over here, towards the outer aspect of the cortex over here. And juxtamedullary means exactly very much close to the pyramids or the junction between the cortex and the medulla over here. Juxtamedullary over here, very much close to the medullary over here. So among these two loops of Henle, this belongs to cortical nephrons and this belongs to juxtamedullary nephrons, because the renal corpus will be over here, the glomerulus will be over here. So the loops of Henle will be reaching till the bottom of the renal pyramid over here towards the papilla over here. Getting it over? So along with the loops of Henle and the collecting tubules or nothing but the ducts of Bellini over here, few other structures will be present over here. What are those? What are those? Arterial recti and there are the vessels which are termed as arteria recti, vena recti. Recti means straight. Anywhere it is straight. Okay. So this is a straight vessel which will be arising from. Efferent arterial or afferent arterial? Efferent arterial. And that will be joining with the venules over here and will be continuous as venae recti over here. So either arterial recti or vena recti, both are termed as vasa recti over here. Getting it over? Vasa recti will be giving rise to a straight vessel, nothing but the arteria recti over here. That will be splitting into multiple capillaries over here. That capillaries will be joining on either sides with the capillaries of the vein over here, and that will be joining and forms the vena recti, and that continues further as the renal vein later on. Okay. So along with the tubules over here, these vessels also can be found within the medulla over here. Got it, everybody? Right? What is it? What is it? Anterosuperior and anterior? What is it?
Superior, anterior lunar artery will be divided into 4 segments.
Okay. Cool. And one more thing, I forgot to tell you the relation between the things over here. Within the sinus, the relations between vein, artery, and pelvis of the ureter. What are the relations over here? Vein will be in front, then will be artery, and then will be the pelvis of the ureter. Okay. So the renal artery will be entering into the substance of the kidney over here and divides into interlobar arteries over here. Is it not? Interlobar arteries over here. This interlobar arteries will be again divided into arcuate arteries over here. This is the interlobar. In between the two lobes is the artery, which is nothing but the interlobar artery. That will be again divided into two arcuate arteries, arch-like arteries on either sides of the renal column. Okay. So these arcuate arteries will be giving rise to straight vessels. Those are termed as what? Interlobular arteries. Lobular arteries. Okay, so far we have seen this is the interlobar artery over here. Then followed by the arcuate artery. This arcuate artery will be giving rise to straight vessels over here. Those are called the interlobular arteries. It's not interlobar, it's interlobular artery. Now we are supposed to understand what is lobule over here. What's the lobule over here? See here properly. So these are nothing but medullary rays made up of what, right? So these are the ray-like extensions of the medulla into the cortex. Getting it on? The renal pyramids are going to give rise to ray sort of extensions into the cortex over here. Those are called the medullary rays, which are made up of the medullary rays contains, so here we have seen the loops of Henle and the collective tubules. And what is the content of the medullary ray over here? That's the difference. That's what I'm asking. Particular arch. What is that? I'm asking what is the content of the medullary rays over here. See, the collective tubules are the contents of the medullary rays. Why so? Because, for example, there is a cortical, what is this? Nephron is present over here. The loops of Henle will be going over here, and the collecting ducts will be entering into this medullary rays over here. Getting it or not? Getting it or not? So the cortical nephrons over here, that will be giving rise to loops of Henle, and that further gives rise to the collecting tubules, which will be entering straight away into the renal pyramid over here. So the content of the medullary rays is nothing but the collecting tubules over here. Multiple collecting tubules of cortical nephrons over here. Juxtamedullary will be entering direct straight away into the renal pyramids over here. But the collecting tubules will be entering into the medullary rays over here. Okay. As a whole, if you see in histology also, If you cut this part and this part, multiple tubules will be seen in the medullary rays and the renal pyramid, apart from the blood vessels over here. Not the glomerulus or the what's that? Bowman's capsule. Bowman's capsule and glomerulus will be in between these over here, in between the medullary rays over here. Okay. So now we are focusing on the what is the lobule of the kidney over here. Lobule of the kidney between exactly one medullary ray on either side will be occupied by interlobular arteries forms a lobule of it. So this part is the lobule of the kidney. You are supposed to know this. Lobe means this entire part is a lobe. Lobule means in between the two vessels there must be a medullary ray. This is called the, so this part is termed as the lobule of the kidney. Get it over? Lobule of the kidney is over here. One lobule contains one this thing and two arteries on either sides. Okay. So one lobule means two arteries on either sides. In the center there will be one medullary ray. So these renal columns, renal papilla over here, and all these lobules and lobes you are supposed to know. Okay. And whenever the what is this part doing? There is a terminology in histology. What is it? The sieve-like appearance of the medulla towards the papilla. What is it? The sieve-like appearance towards the papilla. In histology, there is a term. What is that term? Cribriform something will come. What is it like? What can it? What is it?
Pleats of liver.
No.
Oh, shit.
Lamina cribrosa. Something cribriform will come. I forgot the histology. So, lamina cribrosa. One search lamina cribrosa. Oh, अच्छा. Some cribriform will come. Seem like sea sort of. That's what I thought.
This is sieve-like optic.
In case of kidney, cribriform something will come.
চল তো সবাই মিলে আজকেই বাড়ি চলে যাই
Cribriform area.
ভালো লাগছে
Cribriform area.
গেছিলি বাড়ি
Okay, fine.
যাসনি থেকে বের করে দেয়নি বাড়ি না যাওয়ার মতো
Okay, let us see the papilla over here. We'll finish it off with this. Okay. So this is the renal papilla. This is the base of the renal pyramid. Okay, wherever the apex of the medulla is present, I mean renal pyramid is present, that area is termed as renal papilla. That papilla will be opening into multiple minor calyces over here. Minor calyces. The minor calyces are lined by which epithelium? Minor calyces, major calyces, ureter are lined by which epithelium? That is very much important basic question which you ask in the exams, external exams. And why that epithelium is present in minor calyx and major calyx and ureter also? Why that epithelium is needed? Basic question. So the lining epithelium of minor calyx, major calyx and pelvis of the ureter, and of course the entire ureter is lined by which epithelium and why that epithelium is needed? Come on, right? And never bug up this subject, okay? Try to understand. Simple logical question. The urinary bladder is urinary bladder over or not? Why? Urinary bladder is lined by transitional epithelium. Why transitional epithelium? Straight. Do you think that minor calyces will be collecting the urine or not?
Yes, sir.
What is function of the kidney?
Yes, sir. Yes, sir.
Excreting the urine into the things, no?
Yes, sir.
The ureter and these calyces and everything will be acting as the channels to carry the urine all the way from kidneys towards the urinary bladder. So obviously these parts will be collecting the urine obviously. So do you think that these will be stretching or not?
Yes, sir.
Obviously these will be stretching. So all the way from minor calyces till the urinary bladder, everything is lined by transitional epithelium. And how come the urine contains the toxins, is it or not? Urine contains the toxins or not, right? The urine contains the toxins are not entering into the interstitium over here. Why? Is it alright? We are having the urine passing out through the urethra, that will be collected in the urinary bladder, ureter and calyces and everything. Everywhere the toxins of the urine are present, is it not? All the protein matter, whatever it might be, the bacteria, whatever it might be, everything will be evacuated through the urine over here. Then how come there is a chance now? The wall is made up of transitional epithelium and some muscular external, everything will be, not muscular external, muscular mucosa will be present and muscular layer will be present. So do you think that all the muscle layers which are very much thin in case of ureter and the minor calyces will be preventing the toxins from entering into the interstitium? Then how it is getting prevented?
Transitional epithelium is multi-layer.
So what?
If there is
So what?
single layer, then it will transfer.
No. For example, okay, whenever it is distended, it is becoming 1 or 2 layers, then it is becoming thin, then it can easily enter. Why not? So for example, if the calyces are stretching, the wall will become thin, so 1 or 2 layers will be remained over here out of 4 or 5 layers. Then how come the toxins are from the urine are not entering into the surrounding interstitium over here? You have seen the ureters, no? In the cadaver, you have seen the ureters. How thin they are, just like the vessel they are. So do you think that the toxins can't enter from the urine into the interstitium? No. So try to find out. This is an important question. Or shall I tell you? Tell you what? Oh, very good. Fine, absolutely fine. Okay, fine. Very good. Okay, how the toxins from the urinary bladder and the ureter and the calyces are not entering into the surrounding interstitium over here. Okay, try to find out. It's an important question. Okay. So, when the papilla are entering over here, the papilla are draining the urine from the collected tubules into the minor calyces over here, which are in this cup-shaped form. Is it not? These are the cup-shaped forms. These will become, these cups are concave over here. Is it not? The minor calyces are in this manner. Is it not? This is cup-shaped structure over here towards the surface, towards the papilla. But this will become convex in case of certain condition. So what is that condition if you know? For example, when this can be convex, initially it is concave over here, it will become convex. In what condition, or leave out the condition, in what situation these will become convex over here? Let it correct what is there that. Through urine it can be evacuated outside. So this part is very much important clinically. Okay. Initially the minor calyces are in this manner, collecting the urine from the renal papilla into the minor calyces over here. This is concave in this manner over here. But in certain condition it will become convex over here, pressing over the renal pyramids. In which situation it can occur over here? Accumulation of urine in what manner? How it will occur? Accumulation. Partly it is right.
Obstruction.
Exactly. Obstruction, absolutely. For example, if there is any obstruction over here, the pressure of the urine will be backed up, just like the portal hypertension over here. Normally with some pressure, the urine will be draining into the urinary bladder over here because of the contraction of the musculature over here. But whenever there is a block over here because of the ureteric stone or whatever it might be, so the urine will be collected over here, that exerts reverse pressure over here. So this concavity will become convexity, exerting pressure over the renal medulla, creating the pain over here. Getting it over? So in case of ureteric stones, sorry, in case of ureteric stones, there will be backup pressure that is called hydronephrosis. What is it? Hydro, you can understand the water part over here. Nephrosis, the kidney part over here. Getting it out? So whenever there is an obstruction over here, there will be backed pressure because of the urine. That leads to the loss of this cup-shaped structure into convex parts, exerting pressure over the kidney substance over here. That is leading to the pain over here. So the entire thing is termed as the hydronephrosis, obstruction of the ureter over here, anywhere in the ureter over here. That is leading to backup pressure because of the urine over here. The condition is termed as hydronephrosis over here. Whatever the obstruction might be, either renal stone or whatever it might be. Getting it out? Right? So this renal papilla will be giving rise to draining the urine into minor calyces. Those minor calyces will join together and form the major calyx, and multiple major calyces join together and form pelvis of the ureter. This sequence is important. Minor calyces join together and form the major calyx. Multiple major calyces join together and form the pelvis of the ureter, and further followed by abdominal pelvic part of the ureter. We will be discussing in the next class. Okay? Okay, we'll see the next one.
সবাই চলে যায়